So right now we have a panel and it's called Your Total Care. I told you a little bit about it before I froze up. Your Total Care, Activating Palliative Care. And remember to share your comments in the chat, but if you have a question, we want you to put those in Q&A. So our moderator is Kelly Grosslugs. Kelly is a licensed clinical social worker with a private psychotherapy practice in Minneapolis. She has over 25 years experience helping patients, families, caregivers, and clinicians understand and cope with grief, loss, and traumatic illness. And on our panel is Corinne Whitney. She's the one that gave the quote when we opened up this morning about the storm. She is a metastatic breast cancer survivor who was diagnosed with ER-positive stage 2 breast cancer in 2005 at the age of 33. 10 years later, she was diagnosed with metastatic breast cancer and soon learned the importance of building her palliative care dream team, as she calls it. Dr. Lauren Wiebe is a board-certified medical oncologist and palliative medicine physician. Her practice in North Shore University Health System specializes in the care of patients with advanced cancer. And Dr. Danita LaRue is a licensed clinical and health psychologist with a private practice in Chicago that specializes in working with individuals who are experiencing distress due to chronic, acute, and terminal diagnoses. So welcome, ladies. So happy to have you.
Thank you, Carla. I'm so grateful.
Yes, I'll be back for Q&A.
Okay, wonderful. So I'm looking for Corinne. I don't see her on my screen. Where did she go? Anyways, welcome everybody. Is everybody off of mute? That's the one thing we want to make sure that everybody's off so we can hear you. I see Dr. Wiebe, I see Dr. LaRue, but again, I don't see Corinne. I'm hoping she's in here somewhere. So Corinne, can you say hi? I am not hearing her. Okay, so welcome to our palliative care. As Carla said, I'm Kelly Grosslugs, and Corinne isn't on. Okay, I am a licensed psychotherapist in Minneapolis, specializing in oncology, and have worked on many cases for palliative care. I was on the palliative care service at the University of Minnesota. So I feel like this is just, and I'm so grateful to Chicago Komen for bringing me on. How sad I am that we're not all together, but you know, that's getting old to say. But anyways, Dr. Wiebe, hello, and you are on mute. If you want to just, yep, still on mute. Maybe while you're, there you go.
Can you hear me now?
I can.
Okay, all right. I'm calling in with my phone, so it was a little different, but
Love
hi, nice to meet you.
Hi, nice to meet you. Would you introduce yourself, how long you've been working in the field, and why palliative care you feel is important for patients living with metastatic disease?
Well, I'm actually dual trained and dual boarded as a medical oncologist and a palliative care doctor. So when I was training in oncology at the University of Chicago, I felt like obviously I was getting a high quality education, but I felt like there was just something missing. The sort of extra communication and extra symptom management that I felt like our patients were asking for but didn't even know. And so I went and did formal training at Northwestern in hospice and palliative medicine, which are two different things, but often lumped together. And so I have had a very hybrid career since then. It's been over 10 years since I finished training. And I practice in both areas. So I have my own oncology practice, and then I have also a palliative practice to support other oncologist cancer patients to make sure they're getting excellent symptom management as well.
Wonderful. Thank you. And Corinne's here. Yay. Dr. LaRue, would you mind doing an introduction?
Sure.
Hello.
Morning. Sort of like Dr. Wiebe was talking about how we got here, I'm a clinical and health psychologist. So my focus with my practice is to work with people who are dealing with cancer and other terminal illnesses, as well as their families. As someone who has a mother and sister-in-law with breast cancer, I know how important the referral process is with palliative care, because we've used it on both sides. So it's just really important to know how palliative care is really focused on increasing the quality of life and getting those referrals and being able to feel supported. Having cancer is a lot of work, and people need to feel that they aren't in it alone. And that's what I came into the field to do, and then hired a team of women who all work here with the same process, because we want to make sure we're here supporting people. Because as a Cherokee woman, I understand this marginalized groups process. I was working in Alaska in the villages, and the biases and stereotypes are huge. So how can we notice those and let them come into the room? Because it's important to find people who prioritize diversity for honoring the intersection of the unique identities each person has, so that their resilience can really increase and feel so true to who they are. There's no one right way. And so as facing the challenges of cancer, how to do that and be empowered by your culture and all of the other diverse things about each unique person.
That's so beautiful. I'm so glad you brought that up, because I do think palliative care is such a beautiful bridge for so many discrepancies in healthcare, right? Ethnicity and race being one, but also even diagnoses, which I think is important. So what a great panel. And hi, Corrine.
Hello.
Welcome. Ooh, I love those glasses.
Thank you.
So Corrine, tell us about you and why this was an important topic to have on
Sure.
our conference.
Thank you. So it's kind of a long story, bear with me. So as Carla mentioned, I was diagnosed in 2015, and it was a recurrence from 2005. So I kind of stumbled through learning about palliative care and what it is and how to make it work, and what it really connects for us with quality of life for ourselves and our loved ones. And so hopefully this panel is going to help folks who are kind of getting started on this path. And I think the most important thing, if people don't know, that really palliative care is necessary and folks deserve it. It doesn't mean you're giving up. It doesn't mean you're broken. It doesn't mean it's your sort of last grasp. It doesn't mean you're a diva. I mean, unless you are, but just saying. But really, you and your loved ones absolutely deserve it from day one. You know, just diagnosis is a wallop for everybody. Carla talked about PTSD, and that's real for us and for everybody in our communities. And everybody needs that kind of support. But in order to get it, we really have to ask for it. And that's something that maybe we're not used to doing. And so we're gonna help everybody learn how to do that today. And so my story is not unique at all. I had constant pain for a really long time, and it took a long time for me to actually get re-diagnosed at stage 4. Then of course I was weak from treatments, radiation, you know, oophorectomy, thoracentesis, narcotics, side effects. I mean, all the things. It was really hard. And so again, I hadn't really been introduced to palliative care, but I myself said, okay, this isn't going to work and I need to find other options. And so I started down that road, and I was really lucky to bring together a team of people eventually. It took years to figure out sort of a menu of options for myself. So whatever the challenge, what are some different ways I can address it, and hopefully not completely get my butt kicked every single time. Once in a while, there you have it, right? And that isn't to say that I don't still have side effects, because I do. I still worry about progression. I still am in pain every day. I still fall over from balance issues, but I just manage everything differently. And I could not have figured this out alone. I mean, at one point I had 4 different physical therapists, right? I had shoulder instability, low back problems, lymphedema, of course, the gift that keeps on giving. It turned out that a lot of my issues were long-term damage from my 2005 mastectomy and reconstruction. And this was on top of my stage 4, you know, oophorectomy, menopause, Ibrance, Xgeva, you know, what else you got? Really, you know, one thing on top of another. So I'm really grateful right now to have other folks on my team and a really diverse team of different kinds of health practitioners. Because again, this is more than just fighting a tumor.
Yeah, and I love what you said about team. I think that's the concept we have to look at. It's not you giving up the control, right? It's you being the chairperson of your board, and they're part of your board. I would love to hear from the panelists how you, what would you say to somebody who said, I don't want to offend my oncologist by asking palliative care to come in?
Can I take that one? I feel like a split personality sometimes. No, but I think it's a good thing to realize that it's hard for oncologists to bring up palliative care. So, you know, it's kind of like asking a girl on a first date, I guess. You know, it's sort of like, maybe you want to do it, but you're like, well, I'm running behind on time today. And, you know, then I have to explain it's not hospice. And then people are like, what is that? And so and then it brings up other questions like, are you saying something? What are you saying? And so oncologists are, generally speaking, just nervous to bring it up unless they really have to. I mean, some people incorporate it from day one, but that's not super common. And so usually, and Corinne, you can correct me if I'm wrong, but I think generally, I mean, they might say, oh, well, why? And some of them might say, oh, you're not dying. And you say, well, palliative care isn't necessarily because I'm dying. I just would like some more help with certain aspects of my treatment plan. And someone who's like solely focused on making sure that the whole of me and, you know, this pain and that pain are really addressed in maximal ways. I just want to get another set of eyes on my pain or my symptoms, whatever they are. And usually it looks like, oh, okay, sure, you know, no big deal. It'd be rare if they, you know, really say no. And I think it's more, it kind of takes a weight off the oncologist even, because sometimes they're like, I think I've done everything I know how to do, but I'm afraid to kind of admit that, but maybe I should ask for help. But then there's this whole conversation that has to happen. So I think it's kind of like, I should be fine, I would say. But Corinne, I know she did that, so we'll see what she says.
Well, can you actually fast forward, Dr. Wiebe? So if somebody says, hey, yeah, I need more help, right? And they're able to get to see a palliative doctor, like, what does that look like? What's next for people who haven't done it?
Usually you need a referral to a palliative doc. I mean, even if you're kind of self-referral, that's possible too. So you might just say, hey, to your oncologist or your primary care doctor, can you throw in a referral? And who do you like? Who's good in our area? Who should we see? Who specializes in my kind of thing? And they might find a good palliative care doc or APN for you. And then you have the way I see it and the way most of us are trained is it's just a simple conversation and we're trying to figure out how to help you. And so every single visit I have with a patient is completely different. And so, you know, like Corinne, when you came in, and I know it's okay, we talk about kind of you, because it's part of what we're doing, but, you know, you had your own, you know, you started with saying, I'm a very, you know, please don't take offense, I'm a big advocate for myself. These are my issues. This is what I'm struggling with. I used to see this provider. This is what I've been through. Do you have other ideas? And so we thought of a bunch of things together. And I remember I referred you to Stacy. We did some fascial work for your, you know, some different types of physical therapy or manual therapy to help her with some of the pain she had from the flat thing with the breast cancer surgery. I got her in with an anesthesiologist who did pain because I thought that she needed maybe like a nerve block to that area of her chest. So, you know, I was just thinking, are there ways that we can help her think outside of the box? And so that was what Corinne got. And everybody's different. I mean, some people come to me and they're like, I'm just worried about what's going to happen when I can't take care of myself. And then that's how the conversation goes. So you just don't know what people are bringing. And I just say the conversation is completely open. What do you want to talk about? You know,
Yeah.
and so
I think that's beautiful. Dr. LaRue, can you talk about, because what I've seen as a therapist is when we talking about palliative care to their physicians, some of them actually feel that it'll be offensive because they feel like it's going to, and this is from maybe more of the mental health component conversation that we're having, because they feel like they're giving their physician this message that you're not doing enough for me. And Dr. LaRue, do you see that in your practice?
Yes, I do. And so what we do whenever that comes in, so I get people who come in on their own and people who come through palliative care.
Okay.
And so I educate them on what palliative care is and how they can get these wraparound services as long as they get the right connections, and what wraparound services even mean, and how to get their support system engaged, and how to have this conversation. And we actually do role play in sessions where, you know, I become an oncologist. Let's have that conversation. How did it feel? And what is really important in those is sometimes there are people who just say, I just can't do this. This is so uncomfortable. And so if they have the right therapist and the right crew, or this really diverse team, then the therapist will actually help them with those conversations, or meet with the medical team, either with them or separately based on what they choose. So sometimes it's really important in the process because there is so much coming at you when you have a diagnosis that sometimes you just have to say, Uncle, I can't do this piece. Will you help me in a different way? And hopefully you have the person who will meet you there and be able to help you work with your team, and also find the words to effectively communicate. Doctors, medical doctors are focused on, I've got so much time and I need to hear certain things. Well, patients don't know what we're looking for. So my job, or the way I take up my job, is to help them language the things that are important to the doctor and to them, and how to communicate in a way that's a bridge instead of a bumping up against each other.
Yes, that's beautiful. I'm getting some questions right now that I'd like to ask. Well, actually, we can get to the Q&A. How do you advocate for yourself if your oncologist is not offering services? Now, some of our health systems do not have palliative care. I mean, there may be people tuning in. I know in Minneapolis, we're lucky. But if you go to rural Minnesota, they may not have it. I mean, they say, well, we have hospice. That's not the same thing. And so what do you recommend? What do you guys recommend? How do you advocate for yourself if the oncologist says we don't have that? Is there anything else a patient can do in a system that doesn't have palliative care?
well, I think before the age of telehealth, which is thanks to COVID, it would be hard. But I think these days, I think we're going to have some web links below, like getpalliativecare.org and things like that. But I think that if you're in a rural area of a state, there's probably somebody who's a good palliative care doc at the university hospital or something like that. And so at this point, you can probably just telehealth with any doc you want, anywhere you want, anytime. So, and it would still be covered. You know, if you have like the state health care or whatever, you could probably do within the state. So that would be, that would be a suggestion, I would say, because a lot of what we do is talking about the history of your problems, I mean, so there's obviously some physical exam, but not nearly as much as there would be as in an oncology practice or a general medicine practice. And so much of what we can do is in the conversation. Tell me, have you tried this medication? What happened when they did that? What was the history? When did that occur? And, we can work around stuff. And so I think now, probably better than ever, you can access, good providers.
That's such a great point. So there's one positive of COVID, right? Because
finally.
Finally, we've been waiting for it. Corinne, you're very well spoken. Not all patients have a set of what they want, right? So you kind of made this easy, so to speak, in terms of here's what I want. What are your things, as people are listening, what are kind of maybe 2 or 3 points you could say to the woman or the man that's thinking, this is for me, like, and I'm overwhelmed by this. I don't know.
Yep, there's a ton. And it feels like, you know, oh, now I have to go to a palliative and I have to say everything again. I have to ask blah, 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 blah. And it's kind of like, okay, if you, for whatever reason, cannot find a palliative doctor, as it were, just skip that step, right? You know what your needs are. Oh, guess what? I have insomnia. Ask to speak to a sleep specialist. Oh, hey, guess what? I am in financial dire straits. I'm freaking out. Ask to speak to a social worker, hopefully, who can get you in touch with people who can kind of walk you through that. And again, we're going to post links for triagecancer.org. There's a cancer.net app right now that has a financial link so that you can kind of see and understand more about it. Once again, same thing. You know, if I have lymphedema, which I do, I don't have to wait to talk to palliative to get that service, right? I can say to my oncologist, I need a referral right now, and I don't have to wait for an appointment. I can message them, leave a message on the phone, whatever, and say, I need physical therapy or occupational therapy or both for my lymphedema. I have XYZ pain. I need it addressed. I need a referral for mental health services. I need to talk to a nutritionist to make sure that what I'm putting in my body is actually helping me. I need, you know, help with coordinating my transportation or communicating with my family. Figure out what your needs are and ask for help for that. Please don't wait for your oncologist to mention it. Don't wait to talk to a palliative person. And you're right, Kelly, I am very fortunate that I don't have barriers. English is my first language. I'm really lucky, you know, that I can communicate all of my needs in that way. And again, if you are having trouble in that manner, recruit your community to find the right help. That's one of the reasons for having this conference at all, is to create that community so people can get tips and tricks. And maybe, you know, when you have a call with your oncologist, have somebody who's been a thriver for a certain number of years help you communicate what your needs are. Dr. LaRue, I'd love to have you weigh in on this in terms of that discovery, right? How do people get to that point where they figure out what they need?
Absolutely. So some people really don't know what they need, but when they come in and start talking, that's kind of my job, is to help them find out what it is that we're looking for that would be helpful, how to get that support system, not only just the medical team, but also all of the friends, family, or whoever else. A lot of people come in and it's a secret. They don't want to talk about it. They haven't told anyone. So part of that exploration to find out what you need is each person spending that time to navigate the process together with myself and collaborate or others and say, these are the things I'm running up against. How do I tell my partner? How do I talk to my children? That's what we are trained to do. And if somebody's not trained to do it, next, because this is your body. You get control. And this is empowering because you are taking the steps necessary to get the care that you deserve. Everyone deserves care. So it's really important to really explore and then go, oh, I have this. And then hopefully you're meeting with someone who knows the people in your community and is able to also provide those referrals, even if they're not technically the referrals through the medical system. Right. They have names to go and talk to, and also know that there's alternatives. Yes, first line is going to be medication, but a lot of people come to me and they're like, I've had so many side effects, and this pain is so horrible. So how can we look outside that box too? I love using clinical hypnosis. It helps so much. It doesn't make it go away completely, but it makes your life so much better. Mindfulness, visualizations, and even teaching the children as their parents may be going through this, or children who are going through it, or whoever, how to expand upon their resources and cope in a healthy way. and let their soul be taken care of, because they deserve, everyone deserves that. And I think that's what often is missed. A lot of people come and say, I haven't slept forever. Ironically, with 2 or 3 sessions of a hypnosis that's focused on that, they come back and they're like, oh my gosh, I'm sleeping. So and we record them so they have their tools with them at all times. It's not, you have to come see me because we're virtual anyway. But it's also one of those things of how can you have so many tools that you can pull out of your backpack and go, yep, today I'm going to try this one, or today I'm going to try this one, or this looks not going to work today, but I'm going to pull this one out. And that's part of the process.
Yeah, that's so beautiful. And I want to reiterate what you just said, because I also do clinical hypnosis. Isn't it a beautiful tool? A lot of people are scared by it. They think they're going to cluck like a chicken and all that kind of stuff. And it's not, you know, I'm like, no, I'm not that funny. That's what I always say to people. But another thing, as you guys are talking, what's very interesting to me is palliative care is a whole person medicine, isn't it? I mean, and you brought up soul, which I think is so important. And Corinne, you brought up some beautiful things about different issues that you were struggling with. It isn't just pain, or it isn't just, it's truly quality of life. I mean, when the lymphedema issues and the mental health, thank you for bringing that up, because we have pain and then we have suffering, right? And I think that's where palliative care as a multidisciplinary team can come in, be so beautiful. Most of my patients, most of the people I've worked with, the thing they say they regret the most about palliative care is they didn't have it involved sooner. That's right. I mean, that is truly, I can say almost 99%. And Dr. Wiebe brings up a great point, which is, you know, everybody should have access to it now with technology, if people have technology. So I think that is wonderful. I want to get to some of the questions here. These aren't necessarily directed at any of the panelists directly, so you guys can figure out who you would like to answer. Let's see here. So one of the questions that came is, my oncologist told me I was on palliative care as soon as my TNBC metastasized. Is that the case for everyone?
No, it is not. That person was really lucky to have palliative care engaged right at diagnosis. That's a beautiful thing. Dr. Wiebe, I don't know what your experience is.
I guess I'm not entirely clear what the question was, because I don't know if they, yeah, but I mean, I think you can have palliative care at any point in the journey, you know, even if it's for cure, as long as there's something you're suffering that you need help with. And it can be, you know, a lot of people don't have access to wonderful mental health people who are, you know, trained in kind of existential issues and things, or even, you know, so some people, like some psychiatrists or psychologists, like to stay away from that stuff, which is, I always find interesting. But so we can help with a lot of those things along the way. And so there's never really too early to start. And sometimes it's helpful just to even just meet a person who you know is a nice person, who you can always call upon if you need something more, or something different, or need to just talk about how things have been. And what might be done differently. Yeah. So
I think this was probably more of a, so she has triple negative breast cancer, and right away the oncologist said palliative care is coming in. I think she was just wondering, is this true for everyone? And you guys, you know, Corinne's like, no,
she's lucky. Yeah, she's lucky, I think. But,
lucky, yeah. Absolutely. How about you, Dr. Luru? What do you think from your standpoint? Is that something you see everybody gets this upon metastatic diagnosis?
They should, but whether they get it or not is a totally different scenario. So oftentimes it is, like Corinne said, you know, navigating it and saying, this is what I need to the other providers, and having providers who help you identify that palliative would be helpful, because it really would, it's helpful for everyone, just for different reasons.
Exactly. That's so beautiful. Thank you, you guys. Let's see here. What is the difference between palliative care and holistic integrative care? Do you think we will move away from the word palliative because of its connotation of having a terminal illness?
I feel like it's a little bit of a whack-a-mole game with palliative care, because it's sort of like if you rename something and then that gets the new connotation, then you rename it again. So some people call their program supportive cancer care. Like I think ASCO calls it supportive cancer care for their conferences and things like that when we submit abstracts and talks. I wish that all of it could be provided by kind of one doctor could do everything, as a holistic, whole person oncologist. I guess because of my training, I'm probably like the closest thing you might find to a whole one-stop shopping. But I will say it is, it's tough just from a time standpoint, because palliative care providers, I mean, we book like an hour, 45 minutes for patients. And so oncologists can't really, I mean, it's just, they're usually 10, 15-minute visits. And if they give you 45, that means they're running super late. So it's difficult, given all the people who need to see cancer doctors, to know that we'll get everything in the same place.
Mm-hmm. Yeah.
But I think it's important also, we don't generally talk about quote, cancer. I mean, we're talking about it now, but I think in general, it's kind of like some people keep it hidden and they're afraid of what's coming or what to talk about. And so it's just not part of society. So we can rename it, I think, as many times as we want, but it's the concept that people are worried about.
Yeah.
So that's what we need to talk about.
Yeah. Well, and I think if we can look at it, and I'm seeing some of the comments over here also, and then in my private comment, it feels like this is just a really good start about even awareness, because one of the women here, and I don't know, or man, I can't tell gender, you guys, I'm sorry. So some of the names don't come up through here because I'm getting it through the staff. But one of the things is that people weren't even aware that their oncologist wasn't in charge of all of this. So
Right.
Dr. Wiebe, it's fabulous that you are dual certified. We have a few, but it's kind of a unicorn. We have a very big shortage of palliative care physicians coming out of medical school or even current. And so this is such a beautiful, I'm so excited about this because I'm seeing here some things that show this has opened up even an awareness component about what palliative care is, whether it's the language or not. It's like, this is a service, and that's what we have to focus on. It doesn't mean, and in fact, there's studies that show people actually can live longer when they're in palliative care service. So it's definitely not a giving up. It's an acceptance and embracing things, which is so beautiful.
Sorry, just wanted to step in. Like Corinne had said, if we don't have palliative care located close to us and we don't have that option, then it's sort of looking through the specialties and going, who could help me? And finding people that specialize in cancer, and they should know anyway, what those things are. So if somebody reaches out to me before they reach palliative care, I'm going to refer them to palliative care, but I'm also going to give them referrals for PT and OT and help them find that wonderful team they're looking for, because palliative care has so many facets to it. Even maximizing medical and financial resources. Many people don't know that when they get this diagnosis, they qualify for Medicare. That's a game changer. So there's so many things that are there. So it's really finding people on your team who specialize in cancer and that can help you get there. Even if I noticed a couple of people in this chat are saying how far away people are for palliative care. So this allows you to bring that team in. And again, like Dr. Wiebe said, we're virtual, so we can do things differently right now, which is really fabulous.
I think that is so beautiful. And yes, insurance often covers palliative care. There are situations, maybe some private insurances that don't. But I will say that, even if you don't have an official palliative care team, like what you were saying earlier, one of you was saying it earlier, and it was so beautiful that, but my issues still have to be addressed. So I'm having insomnia, I'm having this, and even if you don't have an official palliative care team, these things should still be addressed. Is that right, Corinne? I mean, would you say that's from a patient standpoint that, okay, if the physician says, we don't have palliative care here, well, A, we have access now to them, but B, okay, well, that doesn't mean that my symptoms just have to sit here. because we don't have it. So what would you say, Corinne, as from a patient standpoint, if somebody is kind of said, well, we don't have that. I mean, that shouldn't really be the last stop, right? Just,
Yep. What I would say is that not everybody thinks in this way, but it might be helpful to consider thinking, oh, look, I have this care team, and we think of it as they're my coaches through this, right? And what I would recommend is that people say, no, this is my team and I'm the coach, right? So I got to get new players. I got to come up with a playbook. I got to coordinate everybody's schedules and all this stuff. It's work. There's no question. This is not, self-care, bubble bath, dark chocolate. No, it's not. It's logistics and all these things. But again, it's really worth the effort.
Yeah.
And so I did see one of the questions, which was really important. Somebody said, so hang on, so I need a referral from my oncologist. And my answer to that is yes. And, put your team to work. So you have a physical therapist who's working on lymphedema. Awesome. Hey, guess what? I also have back pain. Who can you help connect me with? I have a general practitioner, right? My primary care physician, whatever your health system calls it. If you can't get to palliative, that's okay. You tell them, look, I'm having insomnia. My pain medication is, running out after 2.5 hours. I'm having too many narcotic side effects. Help me find something else. Like, put them to work for your oncologist. Again, go to them, but don't stop there.
Right.
That's what I would say.
Right. What do you all think about, somebody here is saying they think that a survivorship program is needed for metastatic breast cancer community. There seems to be a huge gap.
Agree.
I think it's unique because, there can be very long-term survivors who have metastatic breast cancer. So I don't disagree with that. I think that'll be just a smaller sliver. I mean, I know there are some, like I know at Yale, there's Dr. Tara Sands, who's a breast cancer doctor who did palliative care. I trained with her, and then she runs a survivorship program. But that's probably hard to find a lot of places. I think that there are some survivorship resources that you could try to rope into, and then also have someone to help manage symptoms. But, if you're a long-term surviving metastatic breast cancer patient, I mean, at that point, you're mostly quarterbacked by your oncologist, and then who should have some, hopefully, basic skills in symptom management and palliative care. And then if you need something beyond that, I think it's back to what Corinne said, which is figure out the thing that is bothering you and that you might need addressed, and then find that if it's like the psychology of how do I keep living like I'm going to live forever, but I may not. But that's when you find, people like Dr. LaRue and yourself. I think palliative care would be a great place to start, but definitely not the same thing as survivorship. But yeah, you bring up a good need.
Well,
and I would like to make a point that one of the reasons that Dr. LaRue is on this panel is because she specializes in chronic illnesses and how to cope with that. And so if you find, some counselor who just says, oh, I'm so sorry, this is terrible, keep looking, it's okay. Find people who really are suited to what you're doing. Like Dr. LaRue said, if you have a physical therapist who looks at your lymphedema and says, oh, I've seen worse. Okay, I'm going to keep looking because that's not what I need to hear. What I need to hear is how can we make this better? How can we make you stronger? What other support do you need? Garments, the whole shebang.
Yeah.
And again, that's up to us. And the question being, should there be some survivorship specialty down the line? The answer is yes. And the only folks who are going to make that happen is us.
Yeah.
So we have to advocate for that. We have to ask our hospital systems for that if they don't already have it.
Yeah, that's beautiful.
I would also like to add to that as well as I'm also noticing the chat and what people are asking is that when you don't have palliative care as an option that's formal, then it's how to get those referrals and still have continuity of care. And that's where building those dream teams is so important. And having, as Dr. Weeby said, the quarterback for the team and who's the players and how to navigate those. And sometimes you need somebody who specializes with cancer in order to help you wrangle the team and be able to have those conversations and advocate for your needs in the most effective way, while also still getting your personal needs met. And here in Chicago, and I don't know about other areas, but I'm assuming, we have various systems. So you're either a part of like a Rush system or a Northwestern system or all these different systems. And sometimes it's you fire your system and you go to another one. And that's really hard. It's not the best way that people want it to be, but it's your body, it's your care. And if somebody's not meeting your needs, bye-bye. Let's find somebody who's going to meet my needs, because you deserve to have your needs met. And I think that makes a lot.
And there are a lot of examples where, you know, especially if you're your own best advocate. I am the palliative care doctor for numerous patients who are not in my healthcare system for any other doctor. So I take care of a lot of GBM patients who are treated down at Northwestern. But, you know, fortunately, a lot of the computer systems, we can kind of see what the other people do, you know, medical records wise, and we hear from you how things are going as the patient and self-advocate or spouse or whoever it is. And so that actually has worked very, very well. And even like yesterday, I fielded a pretty significant some crisis from a patient who called me because he felt tired, but I identified, I said, this isn't okay. I think you have something acutely wrong with your thyroid and you need to go get labs. You need to call your oncologist and you need treatment like today or tomorrow. I mean, this isn't like, oh, I feel a little tired. So I think, you know, but I knew how to, you know, you got to know who to call. So I'm like, you need to call them and tell them this. And if this doesn't happen, then you probably need to go to the ER. So things can work just fine as long as, you know, and I know, Corinne, we've shared some other doctors from other systems as well. And I think it's how much, you know, as long as you're keeping a pretty decent track of what's going on. And when you go to see a doctor, you know, you can say, oh, you know, my palliative care doctor at that other institution did this or said that. It's very helpful.
Yeah. And I know we only have 5 minutes to close. A couple things to add. So Janice Cowden here is talking about the Elevate Ambassador Program from NCCS. So you may want to look up about that, because I know a lot of people are asking about websites. Another thing that I want to say is because some people are saying, I've never even heard of palliative care before this conference. So yay, it happened. Like this was the reason. But also remember that palliative care, you can still get treatment. You can still get, I mean, it's not about giving up curative treatment or other kinds of treatment. So I think that's another important distinction to make. Sometimes patients have said, but if I go to palliative care, then I can't have my dialysis or I can't have whatever. And that is not true. And so it's, you know, I think that's an important thing for people to remember, because everybody's like saving it for the end. And I think that's the mindset we want to change, that it is something to bring in very early on with a metastatic diagnosis. And so I
always tell people, I just always tell people, as long as you're getting your cancer treatment, your oncologist is kind of the leading actor or actress, and I'm just the supporting actress. You know, I'm around to just make it go better. And then if things flip and you progress and there comes a time where you're not getting any more treatments, we talk about whether it's time for me to kind of take over.
Exactly. So as we're wrapping up, we have 4 minutes. Do you guys just want to end with maybe your 1 or 2 lines about people now as they go forward? This is great in this conference, but what are kind of the 2 sentences you're gonna say that they're gonna go to their oncologist now on Monday, and all these oncologists now are gonna be hearing, "Give me my palliative care." You know, that's what I love about after this. So, kind of, what are your leaving statements? Do you want to start, Dr. Weeby?
I mean, I think that. I think don't be terrified, you know, to bring it up with your oncologist, because they're probably just terrified to bring it up with you, chances are, because they don't want to have to explain what it is. So, as long as and you can even help educate your oncologist that you can have palliative care for 10 years. You can have the same palliative care doctor for 15 years. It's just another way that could help you live a better life. And I did want to point out, especially with Corinne's treatment, like she came to me and she's like, I have pain and I don't want to take a single narcotic. So I was like, all right, so let's figure out how to do that. So let's think outside the box. So it's about, finding someone who's another sort of creative ear to help you solve problems.
Beautiful. Dr. LaRue.
I think my walk away or takeaway is to ask for help. You deserve the support. You deserve the care. Don't be afraid. As Corinne said, don't worry if they think you're a diva. Embrace it. Just be what it is, and get the support you and your family needs, because when they have support, you get more support. So it really is this wonderful thing of allowing the palliative care process to increase your quality of life and give you the best life possible.
Yeah, beautiful point about it also helping those we love, right? Because it's a system approach to medicine. So thank you for bringing that up. And Corinne, we're saving our superstar for the end. So give us something. Like
I better make it good. I do want to reiterate what Dr. LaRue just said. People don't realize, right? So if let's just pretend I'm a cancer patient. Well, I am. So if I'm a cancer patient and my family can't cope, go get palliative care for that. We think it's all on us. We think, well, I'm the patient. I have to fix everything. I have to be perfect. And I'm just this bomb that's gone off and screwed up the rest of the people who I love around me, right? You don't have to suffer through that. That's, not okay. So get the help that you need to help your community cope better, because you guys are all in this together. Yeah. And again, we think that I'm addressing myself, my cancer, my tumors, but your whole community needs help, and there is help out there, but you're gonna have to ask for it and find it.
Yeah, all of you, thank you so much. Thanks for doing the work you do. For all of the people on here, thank you so much. There's lots of resources on here. I'm hoping these chats are available somehow so people can get down there's so many sharing opportunities here. I'm going to turn it over to Carla. Again, thank you to this beautiful panel. And
yes.
Corinne, thanks for really giving words to what other patients are needing, because from a patient perspective, I think it is truly the most expertise that people are looking for is how did you do this and how are you doing this? So thank you so much. And that purple hair, or whatever that is, that purple hair with glasses, I'm guessing that's maybe a recommendation.
I love it. Ladies, thank you so much. There was so much interest in this topic. I'm surprised, but it's a very beautiful thing that you opened our eyes to, because I didn't really understand palliative care. I get it at the Cancer Treatment Centers of America. Everything's there for me. But I travel, you know what I mean? If I was local, it would be very difficult for me to try to put together a team. So everybody's interested. Hopefully the links will get them pointed in the right directions. Thank you so much again.